Welcome to our live webcast, Knee Pain in the Aging Adult, Modern Approaches to Surgical and Non-Operative Treatment. Thank you for joining us. My name is Juliet Davis, and I'll be the operator for the presentation today. Before we get started, I'd like to take a moment to acquaint you with a few features of this web event technology. On the right-hand side of your screen, you'll see a text chat window. There's a large window which holds all your sent messages, and a smaller text box at the bottom where you can type in your questions. To send a question, click on the text box and type your text. When finished, click the send button. All questions that you submit are only seen by today's presenters. Your questions will be responded to in the order which they were received and will be addressed at the end of the presentation. At the conclusion of today's program, we ask you to complete a brief post-event evaluation. Please take a moment to complete this survey in order to receive credit for providing feedback and attending today's webinar. We're joined today by our speaker, Dr. Aaron Forbes, fellowship-trained and joint replacement surgeon. This time, I'd like to turn the microphone over to our speaker, Dr. Forbes, for opening remarks.
Hi, thanks for tuning in tonight. The topic of my talk is knee pain in the aging adult, modern approaches to treatment. I'm a total joint replacement surgeon with Tri-County Orthopedics. Don't have any disclosures for this talk other than the fact that I am, as I said, a surgeon, a joint replacement surgeon, and so some of the things we talk about will be related to that and my experience with it. So the objectives for today, first off, I want to talk briefly about some background. I'm going to try to get through this part quickly so we can spend more time on the actual treatment parts. So that'll be some anatomy and workup and causes of knee pain, and then we'll jump into non-operative and surgical treatment. And then also touch on some aspects of management around the time of surgery and optimization protocols and things that doctors other than orthopedic surgeons can do to help get patients ready and have them have the best outcomes with our treatments. So diving in to knee anatomy, just starting on the surface, the things that you can see and palpate are the femur, the tibia, the fibula, the patella, and the joint line. Going a little bit deeper, you'll see the quadricep muscles, which come into the quadricep tendon, the articular surface of the patella and the trochlea of the femur, and the patellar tendon, as well as the gastrocnemius muscles. There's also articular cartilage on the end of the femur and the tibia. And the meniscus, both medially and laterally, is made of fibrocartilage, where the articular cartilage is made of hyaline cartilage. The main ligaments are the MCL, the medial collateral ligament, the LCL, or fibular collateral ligament, lateral collateral ligament, and then the cruciate ligaments, the ACL and the PCL in the center. So you can really break it down into about three main causes of knee pain in patients over the age of 50. Aging adults, I drew the line at 50. That's kind of where we see things changing. It's either usually traumatic, inflammatory, or degenerative conditions. And to make the diagnosis, we go through the same types of things that we would do for any sort of medical workup, a thorough history and physical exam, imaging, and sometimes laboratory studies. The elements of the history are the same as they would be for anything, and if we focus on previous treatments and the severity of the patient's symptoms, how it affects their daily activities and their quality of life, that'll often drive our treatment. And quality of life, it's important to know, can mean different things to different people depending on their activity level and their demands. So the physical exam begins with an observation of the patient's alignment, their gait analysis, range of motion, and stability testing with varus and valgus stress. Special tests for the ligamentous stability and particular tenderness of any of the different specific areas in the knee. Typical office visit x-rays are somewhat different from x-rays you'd get if you sent the patient to an urgent care or the emergency room. Usually those are non-weight bearing x-rays. You'll get an AP and a lateral and a couple of oblique views looking for fractures. But in the office, weight bearing views are important because that can tell us more about the status of the joint space, Also special views here like the Rosenberg PA flex view shows more the weight-bearing surface of the tibiofemoral joint, and an axial view like a sunrise or merchant view of the patella gives us clues about the patellofemoral joint tracking and thickness of the cartilage. So this is just an example of a normal x-ray of the knee, the AP view, the lateral view, and the patellofemoral skyline or merchant view. You can see that the alignment is neutral, the joint space is maintained, and the height and tracking the patella is where you'd expect it. It is possible to have pathology in only one part of the knee, and an example of medial compartment, isolated medial compartment arthritis is on the left. You can see that on the lateral side of the joint where the fibula is, there's still space between the bones, and that's where the cartilage is, and as well as the meniscus. But on the medial side, that space is gone. It's bone on bone. There are bone spurs there, indicating that there's advanced arthritis in that area. Likewise, on the right side, that's patellofemoral arthritis, where there's complete loss of the joint space and lateral tracking of the patella within the trochlea of the femur. This is an example of severe tricompartmental arthritis with valgus deformity. You can see it's kind of a knock-kneed appearance. There's complete loss of the cartilage in the lateral compartment of the knee, but also loss of the bone stock in the tibial plateau, and gapping open medially, indicating some attenuation or compromise of the MCL. On the lateral view, you can see that there's also narrowing between the patella and the femur. Advanced imaging may be necessary if the x-ray looks normal, or if there's pain out of proportion to the x-ray findings, or if you expect an acute injury. This is an example where the x-ray may look pretty normal, but because the alignment looks normal and the joint space is still intact. However, if you get a CT scan, you could see that there's a depressed fracture of the tibial plateau. An MRI is indicated if you're looking for an injury to the soft tissue or a focal chondral defect. Oftentimes when we get these, we're looking for injuries to the meniscus or the ligaments. But most cases of arthritis do not need an MRI. Labs and aspiration are rarely used, usually for inflammatory conditions or an infection, rheumatoid arthritis, things along those lines. And a rheumatology consult can also be helpful in those cases. So patients over 50 oftentimes have some degenerative changes, some level of degenerative change, whether it's post-traumatic, they've had surgery before that led them to this point, or regular primary osteoarthritis. It's very common in this age group. We see it all the time. Patients say, I don't know why my knee hurts. It just started hurting, or I was going up the stairs or getting up out of a chair, and all of a sudden my knee hurts. So this is very common, and so it'll be kind of the focus for the remainder of the talk. Getting into the treatment, obviously it begins conservatively, and some of the easiest, least invasive things to do would be work on weight loss, less stress on the joints, activity modification, an exercise program for stretching and strengthening, anti-inflammatory medications, whether it's over the counter or prescription, and then injections of various types. Exercises are geared at strengthening and range of motion. That can be through formal physical therapy or just a focused program at home that's directed. And these are a couple of good sources, the ACUS website and the AAOS website. They have exercise programs, a lot of information about knee pain and arthritis, and so if you want to access those, it could be a good resource. Beyond some of those least invasive treatments, injections are often used. It's important to note that these are geared at managing the symptoms. They don't necessarily cure anything, or they haven't been proven to change the course of the disease, but they do help it to feel better and basically treat the symptoms. The most common ones are corticosteroid injections, and viscosupplementation, which is hyaluronic acid. But I think when you're treating patients with these things, the intent has to be known, and they can't be under the impression that you're going to be curing arthritis with these things. There are a lot of misconceptions out there about the gel injections and what they can do, the visco injections. So corticosteroids or cortisone is the gold standard as far as injections go. All the studies compare to this. It's usually mixed with a local anesthetic. It's good because it's inexpensive, it's fast acting, and provides pretty good symptom relief for most people. Viscosupplementation is expensive, it requires insurance approval, and there's really no proven benefit in the literature over a cortisone injection. There's several different types, multiple different formulations from different companies, including the ones listed here. They used to be a series of 3 to 5 injections, but now most of them are one shot. They're smaller volumes and they're synthetic, so we have less negative reactions or pseudoseptic reactions where people have more pain afterwards, and they can be set up on a 6-month cycle. This is some information from the AAOS website, and basically what it says is that this isn't a silver bullet. It can help some people, it doesn't help everybody. It is available and it's approved, and so we do offer it, and a lot of people elect to have it, but you know, the literature doesn't support one way or the other. Biologics are becoming very popular and kind of a hot topic now. There's not a lot of solid data on this either. Overall, they're experimental, and there's limited data and good studies on this. Almost every paper that you read about biologics says more studies are necessary, more data is needed, higher quality studies are needed. And this is the intro to a position statement by AAOS, and it's important to note that here they're talking about advanced arthritis. So this is probably a good source to look up if you're interested, because it brings up some topics about the vulnerability of this patient population that's in chronic pain and looking for any answers to their pain that they've been facing. And they may be willing to pay out of pocket for things that might not help them a lot. It also brings up some concerns about standardization of these materials and the way that they're prepared. It's not all bad, though, and there have been some recent updates to that. I think that one was in 2019. Over the past couple of years, there have been some data that shows PRP, platelet-rich plasma, may be helpful to manage early arthritis. Again, that's manage, not cure, and early arthritis compared to advanced arthritis. So, and it may actually help for longer than corticosteroids, but still hasn't been shown to have an effect on the progression of the disease process. So next, moving on to surgical options. When all the more conservative things fail, surgery is indicated. And before I get into the specifics of some of the surgical treatments, I'd like to touch on optimization for patients prior to surgery. And these are some of the things that we look at, and some of the things where primary doctors and other medical specialists can have a real effect on how patients do, because there are several host factors and modifiable risk factors that can highly influence how the patient recovers from the surgery and their complication rates. So some of the major things that we look at are BMI, and the cutoff that we like to use is 40. That's usually an inflection point in the literature showing worse outcomes above 40, better outcomes below 40. Now you have to add that in with the patient's other risk factors, and some people can't get below that mark, but that's a good thing to include in your workup as to determine whether a patient's a good surgical candidate. Also, smoking status. This wasn't really paid attention too much to in the past, but we know now that it's related to worse outcomes with wound healing problems and infections, as well as diabetes and poor glucose control with A1C levels over 7. Nutrition is one of those things that's over the past few years we're learning more about that and how that affects infection rates and wound healing, and the patient's fitness before surgery can make a big impact as well. So those are all things we would want to optimize ahead of time. Arthroscopy is an attractive option because it's minimally invasive. You're not cutting away bone usually, and it's a relatively quick recovery in general. But it's not good for advanced arthritis. It can be good for meniscal tears, small chondral defects, patients with mechanical symptoms like catching or locking, giving away due to an unstable meniscal tear, something like that, if they have minimal degenerative changes. But as the arthritis and the chondral damage progresses, the success of an arthroscopy declines. And this is an article out of the New England Journal that basically says that arthroscopic treatment provides no additional benefit to physical therapy and medication. So this has been abandoned for this purpose largely. Another surgical option that is very effective in the right setting would be a partial knee replacement or a unicompartmental arthroplasty. This can be done for the medial compartment, the lateral compartment, or the patellofemoral compartment. Those are the three main parts of the knee that we think about. It only resurfaces one of those compartments, and it ignores the other parts. So if you have isolated arthritis or isolated damage to the cartilage in one of those places, this can be a good option. But in reality, only about 10% of arthroplasty patients are good candidates for this. There are good results in some studies with 95% survivorship at 10 years, and even as good results as total knee replacement up to 20 years in appropriately selected patients. This is an example of a partial knee replacement, a medial unicompartmental knee replacement that I did. And you can see that there are metal implants in the medial compartment, both on the tibial and the femoral side, with a plastic bearing, polyethylene bearing in between, while the other parts of the knee are left alone. Some of the benefits to a partial knee replacement are that it leaves a lot of the native anatomy intact. And if there's not a problem with it, it doesn't necessarily have to be fixed or addressed. Patients generally recover a little bit quicker, the incision's a little bit smaller, and most of the time patients will say that their knee feels more normal than usual. The kinematics are better, proprioception is better, and so for the right patient, this can be a really attractive option. The workhorse, however, is a total knee replacement or a total knee arthroplasty. Replacement is a little bit of a misnomer, and a lot of patients are confused when they come into the office and hear about a replacement. It sounds like you saw off the femur and saw off the tibia and take out a big chunk and put in a brand new one, and they're as good as they were when they were 20 years old. But that's not really the case. It's more of a resurfacing procedure. And I'll go over that in just a second, but it's the most common definitive treatment for DJD, degenerative joint disease or osteoarthritis, and the indications are expanding. Most patients fit into that 50 to 80-year-old age range, but younger and older patients can be good candidates for this as well, and the indications are expanding as the implants are improving. So this is an x-ray of a knee replacement that I did, and you can see the implants on the femur and the tibia, the AP view in the center there. There's bone cement. You can see that kind of hazy gray just around the implant holding it in place. The lateral view as well, and the patella is tracking nicely in the trochlea on the left side there. A lot of patients, interestingly, going back to this slide, a lot of patients after the surgery will ask if they have their kneecap. They say, is this my kneecap, when they feel the front of their knee? And you can see over here, I'll try to bring this arrow in, at the front of the knee, yes, you feel your bone there. It's just been shaved off on the back side here, and a plastic implant is there. That's what articulates with the metal. But I would think of it more as a resurfacing procedure rather than replacement is a little bit of a misnomer. There are several different surgical approaches to gain access to the knee, and the idea is to cause the least amount of trauma possible while having appropriate exposure to do the job successfully. So the peripatellar approach is A there, medial peripatellar approach, the mid-vastus and the subvastus approaches have all been utilized with good success. Minimally invasive, those are buzzwords that were emphasized a lot a few years ago. Obviously, everybody wants less invasive surgery, but there was a time when surgeons were trying to make the incision as short as possible, and they were running into problems with inadequate exposure. having implant malposition or early loosening because there were technical errors, and also injuries to the soft tissue like avulsion of the patellar tendon because the exposure just wasn't adequate. So a new meaning has kind of evolved to minimally invasive when it comes to knee replacement, and it's not necessarily related to the length of the incision, although you try to keep it as small as possible, as short as possible, but it's more about gentle handling of the soft tissue, minimizing trauma, and but still being able to see what you need to see. And there are several different types of implants that can be used to perform a knee replacement. Modern designs of implants, they have evolved over the years, but the modern designs allow for high range of motion or high flexion, improved patellar tracking compared to older generations, different anatomy options, sometimes related to a patient's gender, but also just a specific anatomy of each patient, and multiple levels of constraint, meaning the ability to make up for faulty ligaments. There are two main types. They can kind of fit into two broad categories. The cruciate retaining, or CR implants, and that preserves the PCL, and then posterior stabilized, which takes out the PCL, sacrifices the PCL, and the implant substitutes for that. There are a couple subcategories, which I'll talk more in depth about, but medial congruent is one, and mobile bearing or rotating platform is another one. So these are the two basic types of implants that I just mentioned. A posterior stabilized or PS implant refers to resecting or preserving the PCL, the posterior cruciate ligament. And that's a mechanism for providing stability in knee flexion. It limits posterior translation. And for this PS insert, this plastic piece that goes on top of the tibial component, it has this post, and that's what provides that stability and allows the knee to roll back correctly in flexion. Whereas a CR implant over here is open, and it doesn't have that post, and it relies on the native PCL for that action. There are drawbacks, obviously, to both designs. The PS implant requires a larger bone resection, and there can be more noise as that post engages on the femoral component, the metal of the femoral component. So some patients ask about clicking, and I notice that more commonly with that type of design. The CR implant, the drawback there is that it relies on an often pathologic PCL. So you're taking out most of the damaged surface of the knee, but then you leave in a PCL, which may or may not have pathology or damage to it as well. So that can rupture and cause instability in the flexion space, and that's a major cause for revision surgery. This is a technology that I'm pretty excited about and I've been using over the past year or two in the right patients. It's called medial congruent. And the idea is not new. It was developed years ago, but it was limited by the potential of the polyethylene quality. The plastic inserts weren't as good back then. They used to break down and delaminate with shear forces. But they've improved a lot lately, so this technology has come more into the forefront. The idea is that it replicates a more normal knee anatomy and knee kinematics, because the goal as a surgeon and the goal for patients is always to basically have the surgery done and then have it fade into the past and just forget that you ever had it and have it feel like your normal knee. And that's what the idea of the forgotten knee is all about. So if you look over at this picture on the left-hand side, it's an image of the medial tibial plateau, and you can see that the medial plateau is a more concave shape. You can see here, and it has a more rigid meniscus, which acts as a ball and socket, essentially, when the knee is flexing. Whereas on the lateral side, the tibial plateau is actually more convex, and the meniscus is more mobile, so there's more sliding action there. And so the medial congruent knee aims to recreate that type of motion and those kinematics. You can see here it's a shallow, it's a more congruent articulation medially here, and then laterally allows for more of that motion and that translation. It has benefits compared to the PS implant because you don't have to cut as much bone from the femur. This box would need to be resected out of the femur, where it would just be this. You can use a cruciate retaining femoral implant for this this type of articulation. And so it's bone saving, and it doesn't have as much noise, and it feels more normal in my experience. And it doesn't rely on the PCL as well, so it kind of solves two problems there. It does have its limitations, though, with everything else, and we can touch on that in the questions later if anybody wants to. Another technology that I'm really excited about is cementless implants. Again, this is not a new idea, but it's been newly applied to newer, better implants. It's been around for a long time, some of this technology, and it's showed very good survivorship with aseptic loosening as an endpoint. At 18 years, 97% survivorship, so that's excellent. And the fixation is biologic, meaning that the bone grows onto the implant to give it its stability, whereas other knee replacements use bone cement, polymethyl methacrylate, to hold it in place. The day that knee replacement is put in is the most stable it's ever going to be. And conversely, the bone grows onto it and has the potential to really last a very long time. However, the risk is early loosening, so it has to be stable enough initially so that the bone can grow onto it. So there are several things you can do or that need to be done to prevent that early loosening. The bone cuts have to be very precise. The geometry of this implant, especially the tibial component, because that's the most likely to come loose. This particular design has these 4 coated lugs in the central cone, all with this porous surface on them. And a rigid base plate that doesn't wiggle or flex, and also a rotating platform or mobile bearing polyethylene insert. On fixed bearing designs, the ones that I showed you before, this plastic insert, polyethylene insert, snaps onto the tibial base plate and it doesn't move at all. So all the motion comes from here, but any stress that comes through that knee will then be transmitted to the backside of the tibia and risk, there's stress there. It's a risk for loosening. So this allows motion here between the polyethylene and the tibial component, so thereby decreasing that risk. So who's a good candidate for this type of implant? Usually younger patients, higher demand, good bone density. You wouldn't want to use this in someone with poor bone density, osteopenia, or a valgus deformity. It's just not been shown to do as well in those people. In addition to the implants and surgical technique, the way that we take care of patients makes a big difference. So there's been a shift in our thinking. In the past, total joint patients were thought of as sick patients who need to be in the hospital for days and go to rehab for a week or two afterwards to recover. There's been a shift to thinking, hey, these people are healthy. The only thing wrong with them is their knee. And if they do have medical problems, they need to be optimized. They should be as good as they can before surgery to minimize the potential for complications and to speed their recovery. So there's kind of a difference in the thought process of the preoperative clearance protocols as well. It's not like a hip fracture patient who's in the hospital who you're just looking for a risk stratification and some idea of whether the patient's going to make it through the procedure or not. You really want to get this patient teed up and to be as good as possible beforehand to really give them the best chance. And that's where doctors from other specialties can be really helpful in affecting these outcomes. Anesthesia techniques have improved and changed vastly. We usually use a spinal anesthetic with sedation and a regional block, which is an adductor canal block, focusing on the saphenous nerve, which is sensory only. You can use long-acting medication in this that lasts for 3 to 5 days. It's like lysosomal bupivacaine. There's also local periarticular injections, and there can be several different cocktails used for this. But in the past, morphine and opiates were used here, but we've shied away from that now and focus more on local anesthetics and anti-inflammatories. Blood loss is another area where we've made huge gains, and this is one of the things that's made outpatient surgery possible. Tranexamic acid use has really been a game changer for us. We no longer routinely use drains You got to be meticulous about blood loss and hemostasis during the surgery, and keep in mind hydration preoperatively and around the time of surgery to get these patients to where they need to be. Autologous blood donation is a thing of the past, no longer needed with TXA and not recommended. And again, blood transfusions are rare. Other changes that have taken place would be, I no longer routinely use Foley catheters in patients, PCA pumps, long-acting narcotics, CPM machines, or inpatient rehab, and almost nobody. And all these things together, in addition with these wound closure techniques, such as sub-Q closures with stitches and using a dermabond mesh dressing with adhesive occlusive bandages that are antimicrobial. All these things together have made a huge impact on how patients recover early and their ability to take care of themselves and go home, and just simplify the process for them. Nice thing about these bandages is that there's no need for dressing changes. There's hardly ever a patient with wound drainage, and the patients can shower the next day after surgery, and there's something about just being able to take a shower after surgery that makes you feel more human. Again, we like to mobilize these patients as early as possible with full weight bearing. That decreases the risk for DVT and encourages early return to normal and independent function. Some of the things that I mentioned before with the anesthesia, like short-acting spinal anesthetic, also encourages this, because the patients can start moving their legs right away. They can start going to the bathroom normally and get up and move and decrease some of those risks as well. So the focus is getting them back to feeling as normal as possible as soon as possible. Pain control is very important, and some advancements that we've made in this have also allowed us to move patients more to the outpatient setting and to discharge them sooner if they feel better. So it's a multimodal regimen that's usually used, and that includes medications of different types, like Tylenol, Celebrex, Lyrica in selected patients. Aspirin or Ecotrin is used most of the time for DVT prophylaxis, but it's also a good pain medication. And minimizing narcotics because they have a lot of side effects. Nausea and vomiting after surgery in the past was a huge reason why patients had to stick around in the hospital. They just didn't feel good after anesthesia. With the amount of blood loss they had, it all kind of added together to make them feel like they're hungover basically after surgery. So, some of these things like giving them Zofran prophylactically, using steroids, and again, the spinal anesthesia compared to general have made a huge difference with that. So typically patients can expect an early discharge, oftentimes on the day of surgery, but up to 1 to 2 nights in some patients, depending on their health profile and their age. The patients who are optimized, usually younger, relatively healthy patients, are the ones that would be able to get out of there and go home the same day. One of the most important factors is probably their attitude and whether they're motivated and interested. And that kind of begins with the first conversations that I have with the patient and talking to them about how the surgery is going to be. If we're all on the same page, then I think we can get the best result by doing it that way. They should be independently mobile and have a good support system at home. Again, we want to discharge home as opposed to a rehab facility. Better outcomes and less complications. Again, the patients have more contact, more consistent contact with me, and more compliance with my instructions, I find, when they go home, because if they have a problem, they don't just ask the nurse at the rehab facility. They call my office, and I can give them, answer their questions easier than if they're in a facility. Certain situations, though, still obviously require subacute or inpatient rehab stay, and I listed a couple of the reasons there. But at home, having a buddy or a support system, someone who can go through the process with them, be there transportation to physical therapy and things like that comes in very handy. So patients can expect physical therapy for usually 6 to 12 weeks after the surgery. They can have it in the home for the first couple of weeks if it makes it easier for transportation purposes, or go straight to outpatient physical therapy. To give patients kind of a timeline as to when they'll be able to do certain things. Everybody wants to know what they'll be able to do after the surgery. So usually for a desk job, it would be somewhere in the 2 to 6 week range. An intermediate job, say a teacher or something where they're more active, maybe 4 to 8 weeks. Heavier duty labor jobs or any sort of sporting activities would be more like 3 to 6 months after surgery. And in reality, patients will see continued improvements, especially with regard to strength and endurance for several months to a year after surgery. So a lot of patients ask about the things that they can do. They all want to know how this is going to impact them and what types of limitations they're going to have after the surgery, because in the past there were a lot of them, but they're becoming much more lenient now with the better implants and techniques that we have. So after surgery, the answer usually is that there aren't that many limitations. In general, we favor low-impact exercises and activities with a relative limit on running and jumping. But it's okay to bike, swim, use the elliptical, golf, ski, tennis. And the general thought is that patients can return to their prior level of sport or activity. They shouldn't be taking up new hobbies where they could get injuries. That's generally recommended against, but it's also important to know that they should progress gradually with strength, and long-term strengthening is important to prevent injury. As with any surgery, there's always a potential for complications. There's risks. I've listed a few of those here. Infections, 1 to 2%, pain and stiffness, instability. I've touched on that a little bit before. VTE, cardiac issues. Those are all possible, but relatively low risk. I want to touch a little bit on some evolving technologies next. These are kind of hot topics in the area of joint replacement, and a lot of patients come in asking about them because they're heavily marketed. Computer navigation and robotics are two of them. And robotics has been applied to a lot of different surgical fields, so that's obvious why patients are exposed to that, and it's kind of a hot topic. Patient-specific implants and instruments were kind of a fad a few years ago. I don't see those around very much anymore, and don't personally know any surgeons who use them, but they're basically where you could get a CT scan, and particular implant companies would then give you the correct implant sizes based off that, or give you blocks to use during surgery to make the cuts based off the patient's anatomy, but oftentimes they didn't fit perfectly, they didn't work out that well, they were a little finicky. There were some technical errors, and oftentimes surgeons would have to revert to using the standard techniques anyway. Computer navigation, however, although it's not usually necessary for routine cases, it can be a very helpful tool in certain cases. Say there's a large extra-articular deformity or retained implants that you have to work around. This can be very helpful and very precise. The systems have gotten much better. They usually use cameras or accelerometers to calculate the correct angles for the cuts. This is a patient of mine that had an intramedullary nail in his femur and his tibia, and we had to try to find a way to work around this to do a knee replacement. So the tibial nail and the hardware had to come out. There was really no way to work around that, but it was easy because the incisions were around the knee and it could all come out from the same site. Taking that rod out of the femur would have required another incision, basically another setup and exposure to get it out from the hip proximally. So instead, we use computer navigation because usually when you're lining up the femoral component to get the mechanical access, or actually the anatomic access, and estimate the mechanical access, you would access this intramedullary canal. But with the rod in place, you can't do that. So that's where the navigation comes in handy, because it calculates the center of rotation of the hip and the knee. so that you can get the implants aligned appropriately. Like here, and then here for the tibia as well. The mechanical axis and the anatomic axis are the same for the tibia. But you can see how we were able to get that in there. We used a cruciate retaining femoral design for this with the medial congruent bearing that I mentioned earlier, and we're able to save time and effort and morbidity related to the other incisions potentially by doing this instead. Robotics. These are basically the two robot systems that are available. They consist of these large consoles, these bases with a robotic arm that's attached, and they have computer screens that allow you to interact with it. There are pros and cons to this. The thought is that it decreases outliers and errors, human errors. You can do a pretty thorough preoperative planning and kind of estimate where your cuts are going to be on the computer screen before making those cuts during a surgery, as opposed to traditional means. It's evolving quickly, and there's constantly new updates coming out and new models, kind of like anything with technology. It improves pretty rapidly, and it can be helpful for if surgeons have difficulty with alignment, or if they're not doing a lot of total joints. It can really help to decrease those outliers. But in general, at this point, most of the total joint surgeons that I know that do a lot of knee replacements don't use this on a routine basis. Some of the drawbacks to it are that some systems require a CT scan, which requires radiation, or it is radiation. There are reference pins that go into the tibia and the femur, and there's a potential for pin site complications like infections and fractures. Increases the operative time, and to date, there's really been no proven clinical benefit. But as I said, these things are evolving and evolving pretty rapidly. This is actually a new system that's supposed to be coming out later this year. It's nice because it's smaller. It just is this smaller part that kind of attaches to the side of the operating table. It's more intuitive. There's no CT involved. You can take measurements from in surgery as you would normally with traditional methods like we do now. And so it really doesn't change the workflow that much. So I'm kind of excited to see what this has to offer, and we'll see if it can make a difference. So there's continued evolution in this field where we're fine-tuning treatments to become more broadly applicable, especially with regard to joint replacement surgery. It's improved dramatically over the years with regard to the surgical techniques, the implant design and fixation, the perioperative protocols, including blood loss and pain control especially, and patient optimization. And how we treat the patients medically and their other conditions around the time of surgery. This has allowed a shift to treating more patients effectively with faster recovery, shorter hospital stay, and better outcomes. So the future holds most likely expansion with these digital solutions, and we'll see more improvements in the areas of navigation and robotics. And even smart implants. There's one company that's working on a knee implant that will talk to an app on your cell phone. So obviously there's no clinical data on that, and who knows if it'll actually make a difference in how patients do, but those are things that will be coming up in the future. So these are just a couple of selected references for CME purposes, and thank you for your time and attention. And I guess we'll open it up to questions now. This is my email address. Anybody who doesn't get to ask a question or wants me to go into depth on any more of these topics, I know I kind of blazed through a lot here, but you can reach me at the email above. So thank you.
Great. And just as a reminder for our audience today, the text chat is located on the right-hand side of your screen. To submit a question, type your text into the small text box at the bottom. When finished, click the send button, and we will wait for some questions to queue.
So I have two questions here. I just click on them to read the whole question.
Correct.
I have one question here. Do I use cement or use biologic ingrowth? The answer is both. Like I said on that slide, it depends on the patient. I usually use biologic cementless implants for patients with good bone density and good bone quality, and patients where I really want to have solid fixation for a long time. The truth is, cemented implants are great. They have really good track record, and they last a long time as well. I mean, we hope these things last for 20 or 30 years, but there's always a weak link in every construct. In the past, it's been the polyethylene inserts, the plastic, but those have improved vastly. And so besides that is the link, the bone implant interface. So something has to give at some point, and I think that in certain patients, cementless implants are really, really a great option. So I have a lot of patients, some of them, one guy I can think of in particular who's a referee for soccer, and he runs up and down the sidelines. He's young, I think he's 50, and so he was a really great candidate for this. So yes, it's an option that I use, and I think I'm expanding and will use it even more because it's been a really great implant. Moving on to the next question. What is your thromboprophylaxis protocol? So aspirin for most patients. We use an enteric-coated aspirin unless the patients are at high risk, have a history of DVT, recent history of cancer, some other reason why they would be likely to develop a DVT or PE. Part of the prophylaxis protocol is that early mobilization and getting patients up and moving, using a short-acting spinal, discharging them home right away so that they have to move around. But recently, over the last couple of years, there's been a lot of literature supporting aspirin and even low-dose aspirin, like a baby aspirin twice a day. I usually do that for 4 weeks. And in patients who are very active and mobile, I'll decrease it to 1 baby aspirin after 2 weeks. Because you have to remember, it's always a balance between thinning the blood too much so patients have bruising and swelling and potentially wound drainage, complications related to that, as you see a lot of times with things like Lovenox and heparin and higher-powered Coumadin. When we used Coumadin for this years ago, we saw a lot of those complications. Patients became super therapeutic. So aspirin's really been great. Another benefit to the aspirin is that it helps with heterotopic ossification formation. So that's a kind of a side benefit to it. And it's also a pain medication, so it's really a good option for most people. Let's see. Next question. If I'm 72 years old, can I get an uncemented knee? Yes, if you meet those criteria. It's something that I would definitely offer up, but if usually someone who's osteopenic, lower bone density, maybe women, especially a valgus deformity where the knee is knock-kneed and there's more lateral wear than medial wear, those are situations where that initial fixation is not going to be as solid, and I'd be more concerned about early loosening. So I'd be a little more hesitant to use an uncemented implant in those people. Another funny thing is that some surgeons link or equate cementless implants with robotic surgery because they think that's the only way that you can get cuts that are precise enough, and that's just not true. You just have to take your time and make sure that you're doing a good job of getting good cuts and a good solid press fit with the implants. And also the implant design, the one that I showed you, is really the only cementless implant that I would use at this time. But for, I would say for the majority of people, I still use cemented implant. Next question. I have a patient who had a total knee about 10 years ago. Let me slide this over. I can't read the whole thing. She now has a stress fracture of the femur. Can she get another rod in the femur? That is hard to tell you without seeing the x-rays and knowing the story a little bit better. But yes, we can always fix it. Lots of patients have periprosthetic fractures, you can fix fractures around the implants. If it's a stress fracture that's non-displaced, a lot of times that can be treated non-operatively. And if it's a fracture that compromises the stability of the implant, that can be revised or do a redo replacement. So I do all those things, and yes, it can be fixed. Those are all the questions that I see for now. All right, so I think that's it. Again, thank you so much for your attention and your time this evening. My email address is there. Feel free to reach out, and have a good night.
Great, thank you. On behalf of the Atlantic Health System Morristown Medical Center Orthopedic Surgery, I'd like to thank you for your presentation today and your participation in today's event. You'll now be redirected to a post-event survey requesting your feedback. Please take a moment to complete this survey in order to receive credit for providing feedback and attending today's webinar. This concludes today's program. Thank you all, and have a great day, everyone.